Voy a hacer algunas observaciones en base a algunos estudios. La primera asociación de criptococosis con el síndrome de inmunodeficiencia adquirida, que en esta época todavía no tenía ese nombre, se hizo desde el 83 y ven aquí en esta diapositiva a la izquierda un pulmón con tinciones especiales y se ve neumonía por Pneumocystis carini y Cryptococcus pseudoformas, como se llamaba en esa época. Tenemos también la situación del VIH en América Latina. A nivel mundial ha habido una disminución importante de las nuevas infecciones en estos últimos 10 años y lamentablemente en América Latina este no es el caso, ¿verdad? Tenemos una epidemia que sigue presentando la misma cantidad de infecciones nuevas cada año. En el Caribe la situación es un poco mejor y lo que sí ha disminuido notablemente es la mortalidad, pero no tanto como en el resto del mundo, ¿verdad? Entonces tenemos todavía mucho trabajo por hacer para disminuir nuevas infecciones y para reducir la mortalidad. Vemos en estas diapositivas ahora, por ejemplo, que criptococosis en Brasil representaba el 20% de la mortalidad asociada a VIH en los 12 años del 2000 al 2012. Y vemos cómo las tasas de criptococosis eran mayores en el sur del país. Tenemos estas tres presentaciones donde vemos cómo la histoplasmosis es bastante prevalente en la región. Se estima que hasta un tercio de las personas están expuestas a histoplasma. Se podría pensar que en escenarios moderados, si son sintomáticos el 50% de los casos de infección y si hay una tasa de fatalidad de 20%, que en la región habría más o menos 11.180 casos por año con 2.200 muertes. Aunque en el peor de los escenarios podría llegar hasta 15.600 casos y 9.000 muertes. Hay un alto nivel de coinfección con tuberculosis y la TB y histoplasmosis podrían representar el 20% de las causas de mortalidad. De la misma manera, en este artículo del Caribe, esta revisión sistemática, se ve que la histoplasmosis es una primera infección oportunista en un porcentaje muy alto de los casos, 40-70%. La mortalidad es bastante alta en esta revisión también, 22% en Guyana a los 6 meses y 30% en Brasil después de un poquito menos de un año, aunque la mortalidad disminuye 50% después de iniciar tratamiento y efectivamente más del 90% de los casos son enfermedad avanzada y probablemente diagnóstico tardío también, ¿verdad? Con menos de 100 CD4 por minuto. Vemos que a pesar que el diagnóstico tardío ha bajado en la región de 33 a 25% en los últimos años, sigue siendo muy, muy alto el porcentaje de pacientes que se diagnostican con menos de 200 CD4, yendo desde un 44% en Paraguay, pero también 39% en México, 38% en Panamá, 35% en Colombia, 30% en Chile, o sea, sigue siendo muy, muy alto. Y vemos cómo Perú y Uruguay, al contrario, tienen solo 16 y 10% de pacientes diagnosticados con menos de 200 CD4. Vemos en esta diapositiva que el diagnóstico tardío es más alto en adultos mayores. Y en esta vemos cómo si elimináramos el diagnóstico tardío se podrían reducir las muertes por VIH hasta un 86%. Y en Latinoamérica, la mayoría de las muertes se atribuyen a enfermedad avanzada y un poquito menos al retraso en el inicio del tratamiento. OMS y OPS han desarrollado guías para reducir la mortalidad en enfermedad avanzada. Ven esta primera guía del año 17, la segunda para el manejo de criptococo del año 18 y la tercera del año 2020 para el manejo de histoplasmosis. Se proponen, por lo tanto, intervenciones para reducir la mortalidad que básicamente están asociadas, por supuesto, con el conocimiento del estado serológico. Si la prueba es negativa, habría que evaluar el riesgo del paciente y si esta evaluación es positiva, poner a la persona en prevención combinada de VIH, incluyendo PrEP y testeo periódico, sobre todo si es una población clave. Y si la prueba es positiva, pues el inicio temprano del tratamiento antirretroviral con algún régimen que contenga dolutegravir y evaluación y manejo de la enfermedad avanzada. Creo que aquí terminé la presentación, sí. Entonces, con esta pequeña presentación, doy por concluida mi participación en la reunión y les deseo que tengan una excelente reunión. Muchas gracias.
Muchísimas gracias, Rubén. Soy Omar Suet, soy asesor regional de tratamiento y atención aquí en la Organización Panamericana de la Salud, y para mí es un placer poder tener hoy a todos estos participantes que están conectados para este encuentro. En este momento tenemos más de 115 participantes y tenemos una agenda muy cargada y muy interesante para compartir con todos ustedes durante estos próximos 3 días. En la primera, digamos, la idea es recapitular de alguna manera todos los esfuerzos que se vienen haciendo en el manejo de las enfermedades fúngicas en la región, desde el primer encuentro que hubo en 2015 en Paramaribo, con el primer encuentro de histoplasmosis en América, después la iniciativa 80-20 que dio lugar a esa reunión, el encuentro de histoplasmosis en el año 2019 que dio lugar a las guías de tratamiento de la OMS, a la declaración de Manaus, y también a la revisión de la situación de los laboratorios en 2019 en Gafi. El encuentro de en esta ocasión, el objetivo de este encuentro es generar conciencia sobre las intervenciones críticas que pueden reducir realmente la morbilidad y la mortalidad. Examinar también los recursos que tenemos para gestionar estas enfermedades relacionadas, discutir soluciones concretas de implementación de pruebas de diagnóstico rápido, compartiendo lecciones aprendidas con países que han avanzado en la implementación de estas tecnologías, compartir experiencias en la implementación de las directrices de la OMS y revisar también conocimiento científico. Y por eso tengo el placer de introducir el primer panel que va a estar a cargo del doctor Tom Schiller, quien es médico, epidemiólogo, máster en salud pública y jefe de la rama de micosis de los Centros de Control de Enfermedades, para que dé lugar a la primera sesión sobre epidemiología y guías globales de tratamiento en el día de hoy. Así que, Tom, adelante con la introducción y la primera presentación.
Thank you. Buen dia, good morning, bon dia. My name is Tom Schiller, as Omar has said, and I have the pleasure of introducing the first 3 speakers of this meeting. Excited to have all 3 of them today. And I know we started a few minutes late. So without further ado, let me introduce the first speaker, Beatriz Grinsten. I hope I pronounced your name okay. Is an infectious diseases physician, scientist with over 3 decades of experience in HIV care and research. She's based in the Evandro Chagas National Institute of Infectious Diseases, Fiocruz, Rio de Janeiro, Brazil, where she's the director of the STI HIV Clinical Research Laboratory and principal investigator of the Fiocruz Clinical Trials Unit. Beatriz will talk about advanced HIV disease and its most frequent complications. Beatriz, over to you. Obrigado.
Gracias, Tom. Consegue ver minha tela? Is it possible to see my screen?
Sí, Beatriz.
It looks good.
Thank you so much. So first of all, thank you very much for, Thank you very much for the kind invitation to be part of this great workshop and on such an important topic for our region. So I will start this session discussing a few aspects of advanced HIV disease and most frequent complications very briefly. So by the end of 2019, there were 38 million people, I'm sorry, I will speak in português. Ao final de 2019, haviam 38 milhões de pessoas vivendo com HIV, tendo ocorrido 690 mil mortes e uma estimativa de 1,7 milhões de novas infecções ocorrem a cada ano. Sendo que 1,7 milhões em 2020, 3 vezes mais alta do que as metas da Analyses. Nesse slide, vocês podem ver que o número de novas infecções pelo HIV permanece bastante alto e completamente estável nos últimos 21 anos na nossa região. Nesse gráfico, vocês podem ver que entre 2010 e 2020, a diminuição das mortes relacionadas à AIDS foi menor na América Latina quando comparada aos níveis globais. E o número de novas infecções, como nós já dissemos, não diminuiu em nada. Então, apesar de nós estarmos oferecendo terapia antirretroviral o mais precocemente possível após o diagnóstico do HIV, o diagnóstico do HIV continua sendo feito num número substancial de pessoas quando os mesmos já têm doença avançada pelo HIV, definida pela Organização Mundial de Saúde como um CD4 menor do que 200 células. De uma forma global, mais de 30% das pessoas no mundo são diagnosticadas com HIV já no momento de doença avançada, sendo que esses indivíduos estão sob risco aumentado de morte mesmo após o início da terapia antirretroviral por conta de resposta inflamatória exacerbada. E esse risco aumenta com células CD4 mais diminuídas, obviamente. Essa tendência, de forma muito preocupante, tem sido observada mesmo em países como o Brasil, que tem programas muito bem estabelecidos de terapia antirretroviral de longa data, e porque não só essas pessoas se apresentam tardiamente para o cuidado, mas também se apresentam reapresentam após interrupções do tratamento. E como vocês podem ver nesse mapa, na nossa região é muito importante o número de pessoas que se engajam no cuidado muito tardiamente no decorrer da doença, da infecção pelo HIV. A definição de doença avançada pela Organização Mundial de Saúde para adultos e adolescentes e crianças acima de 5 anos, a doença avançada é definida como CD4 abaixo de 200 células ou a classificação 3 e 4 da Organização Mundial de Saúde na apresentação para o cuidado. E com relação a algumas estimativas, na nossa região, em torno de 50% dos homens e um pouco mais de 30% das mulheres chegam ao cuidado com CD4 abaixo de 200 células. Como nós já mencionamos, é muito importante lembrar que não somente as pessoas que chegam para o cuidado, mas também aquelas que estão se reengajando após um período de perda de segmento, de desistência do tratamento antirretroviral, e essa última questão, principalmente, é um desafio enorme para os sistemas de saúde para reabsorver essas pessoas num tempo rápido, para que elas possam se beneficiar do que temos disponível, bem como também leva a desafios do ponto de vista dos novos esquemas antirretrovirais a serem iniciados após a interrupção. Nós podemos ver, então, esquematicamente nesse slide, a lista de problemas relacionados à apresentação tardia para o cuidado, que são a mortalidade precoce, a alta incidência de co-infecções, principalmente no nosso meio a tuberculose, e as infecções fúngicas e as infecções bacterianas, a mortalidade importante nessas pessoas que se apresentam com CD4 baixo, particularmente aquelas com doença disseminada por tuberculose e por doença fúngica, e também o aumento possível de reações adversas, por exemplo, a reconstituição imune pelo tratamento da tuberculose. Também, essas pessoas que se apresentam tardiamente têm um maior risco de perda de segmento e, naturalmente, elas representam um custo maior para o sistema de saúde. Nesse slide, nós podemos ver uma versão revisada da cascata do cuidado contínuo, que foi proposta há poucos anos atrás por pesquisadores, incluindo o Nathan Ford, que também vai ser parte desse evento. Essa cascata eu achei muito interessante trazer, porque ela define, ao longo dos momentos específicos do cuidado, o reengajamento, ou seja, não só o momento que essa pessoa se apresenta e como ela transita ao longo da cascata de cuidado, mas também os diferentes momentos onde ela pode ser perdida de acompanhamento e se reengajar. Então, essa é uma cascata de cuidado que é bastante realista do ponto de vista do planejamento das ações, e ela pode informar na priorização dos esforços a serem feitos pelos profissionais de saúde, pelas comunidades, pelos diretores de programas, pelos donors, onde existem donors, para que se possa, de antemão, prevenir essas visitas clínicas onde os indivíduos não aparecem, para que a gente possa facilitar as barreiras na reentrada do cuidado, minimizando, então, em todas as instâncias, em todos os momentos, os riscos desse indivíduo avançar para uma doença avançada pelo HIV. E esse entendimento dessa cascata melhora a nossa possibilidade de diminuir a morbidade, a mortalidade e diminuir a transmissão pela forma de antecipar os eventos e reduzir dessa forma os gaps no cuidado. Embora na nossa região o contínuo do cuidado tenha melhorado ao longo do tempo, nenhum dos nossos países atingiu os alvos 95, 95, 95 estabelecidos pela UNAIDS. Os números anuais de novas infecções, como a gente já mostrou, estão inalterados nas duas últimas décadas, e a mortalidade também é bastante heterogênea na nossa região. Então, isso pode ser, como a gente já mencionou, bastante explicado pela alta e persistente frequência do diagnóstico tardio na nossa região, para a qual estratégias inovadoras são necessárias para que a gente possa ampliar a testagem do HIV e a inserção precoce no cuidado. A apresentação tardia, ela, como eu já disse, ela é muito comum na América Latina. Então, nesse artigo, que é um artigo que foi produzido dentro da colaboração Cassanet é uma coorte multicêntrica que engloba centros em vários países da nossa região, Brasil, Argentina, Chile, Peru, Haiti, Honduras. Vários países da nossa região fazem parte dessa grande colaboração Cassanet, também em colaboração com a Universidade de Vanderbilt, que é o centro coordenador, e nós somos parte da rede maior IDEA, que é uma rede de bases de dados longitudinais, justamente para estudar as tendências da epidemia nas diferentes regiões. Então, nesse manuscrito, dentro da colaboração Cassanet, nós estimamos o risco atribuído, ajustado e a fração atribuível populacional para a mortalidade de todas as causas na apresentação do cuidado em pessoas que se apresentam com doença avançada. Nesse artigo, nesse trabalho, nós incluímos quase 10 mil indivíduos, sendo que 56% deles se apresentaram com doença avançada pelo HIV, com CD4 abaixo de 200 células. Então, esse risco atribuível de doença avançada para a apresentação tardia foi de 86%, 71% e 58%, e as frações atribuíveis populacionais foram de 78%, 58% e 43% nos períodos de 1, 5 e 10 anos após a inclusão no cuidado desses indivíduos. Entre indivíduos que se apresentam com doença avançada, isso foi extremamente importante também. Então, quando a gente olha para a contribuição da terapia antirretroviral, ela foi capaz de diminuir esse risco de morte em 63% no primeiro ano após a inclusão no cuidado. Então, mais uma vez comprovando que a apresentação mais precoce no cuidado vai prevenir a maior parte das mortes na nossa região. A mortalidade precoce, ela acontece na enorme maioria das vezes devido à situação imunológica bastante comprometida desses indivíduos. E, como já disse, no nosso meio, infecções como tuberculose, infecções fúngicas e bacterianas disseminadas são as causas mais importantes de morte. Só para relembrar, o estudo Clinical Trial Reality, que foi capitaneado pelo nosso grande amigo que faleceu esse ano, James Hakim. Esse estudo foi publicado em 2018, e esse estudo mostrou que, mesmo na presença da terapia antirretroviral, a mortalidade causada por tuberculose, doença meningea fúngica por criptococo e doença disseminada bacteriana permaneceu inaceitavelmente elevada, mesmo em indivíduos em uso de terapia antirretroviral. De forma global, as causas mais importantes de mortalidade são essas, como a gente já disse, a tuberculose, infecção bacteriana, infecção fúngica, e nesse slide nós vemos resultados de uma meta-análise que reportou nas causas de admissão hospitalar em indivíduos vivendo com HIV até 2015, analisando em torno a mais de 300 mil hospitalizações entre adultos e mais de 6 mil hospitalizações em crianças com HIV. E nós podemos ver que, nessa enorme meta-análise, incluindo esse número grande de pacientes, as doenças relacionadas à AIDS e as infecções bacterianas se mostraram as mais importantes causas de hospitalização e também as causas mais importantes de mortalidade em todas as regiões do mundo. Agora, falar um pouquinho rapidamente da tuberculose. A tuberculose é a maior causa de hospitalização e morte entre adultos e crianças vivendo com HIV no mundo, e ela representa 1/3 de todas as mortes registradas em 2019. A tuberculose e o HIV, elas têm uma interface que encontra também as populações mais empobrecidas, particularmente vivendo em locais com alta densidade populacional, como as favelas, nas prisões, entre indivíduos que usam drogas, entre migrantes, que são uma questão hoje fundamental para a nossa região, e essas questões ambientais devidas a condições precárias de moradia e a densidade alta, também associadas a outros fatores individuais, como o uso de álcool, uso de tabaco e subnutrição, criam o ambiente perfeito para uma maior transmissão da tuberculose, e exacerbado pelo pouco acesso ao cuidado que existe ainda em vários locais na nossa região. De forma importante, a tuberculose já mostra um aumento que a gente espera que vá ainda piorar em relação ao impacto da pandemia de Covid na nossa região. Então, a expectativa é que as questões relacionadas ao diagnóstico tardio e principalmente ao diagnóstico de tuberculose e das infecções fúngicas possa ainda piorar no contexto de toda a piora que nós estamos vendo após a pandemia de Covid, que não só captou grande parte dos recursos, mas também diminuiu de forma ampla o acesso aos serviços de saúde, pois os mesmos se mostraram bastante tomados pelos pacientes com Covid. Como vocês sabem, a mortalidade durante o tratamento por tuberculose é também importante e ela é diferente de acordo com o momento, com a situação de imunossupressão desse indivíduo. Nesse estudo que nós conduzimos no nosso instituto, na Fiocruz, nós avaliamos indivíduos que começaram terapia antirretroviral entre 2000 e 2010 com o diagnóstico de tuberculose. E nós classificamos as causas de morte utilizando o protocolo CODE, que padroniza essa classificação das causas de morte. Então, durante o primeiro ano após o diagnóstico da tuberculose, a mortalidade se mostrou maior durante os primeiros 3 meses, sendo em torno de 44% pessoas ano nos primeiros 30 dias e 28% pessoas ano entre o 30º e 90º dia, sendo que a infecção bacteriana invasiva se mostrou a maior causa de morte entre pacientes com tuberculose. E o risco de tuberculose no primeiro ano, de morte nesses pacientes no primeiro ano foi de 13%, e os principais fatores foram um CD4 de apresentação menor ou igual a 50 células, o uso de ventilação mecânica e a apresentação sob a forma disseminada de tuberculose. Passando agora para a questão das infecções fúngicas, 50% das mortes por HIV globalmente são relacionadas à infecção fúngica, e isso depende de forma muito importante da capacidade diagnóstica e das opções terapêuticas que nós temos. Os subdiagnósticos e os diagnósticos perdidos contribuem de forma muito importante para essa mortalidade precoce e parcialmente, sendo que parcialmente a responsabilidade disso é de questões relacionadas a restrições dos diagnósticos em indivíduos, principalmente em indivíduos com doença avançada. As doenças fúngicas graves podem afetar mais de 2 milhões de pessoas anualmente na região da América Central, América do Sul e Caribe, com mais de 350 mil casos de infecções muito graves. Nos últimos 10 anos, a gente tem presenciado uma revolução no diagnóstico das infecções fúngicas e movendo para o diagnóstico molecular. Entretanto, que leva a uma velocidade maior, uma facilidade maior do diagnóstico. Infelizmente, ainda, apesar de todos os avanços e apesar da nossa região ter, desde o início, se engajado nessa melhora da capacidade diagnóstica, infelizmente, ainda poucos pacientes têm se beneficiado dessas tecnologias mais modernas. Só para exemplificar, no nosso instituto, nós construímos um projeto de cooperação com o Ministério da Saúde. O Rio de Janeiro é um lugar onde nós temos o segundo maior número de casos de AIDS no país e, além disso, somos o 3º estado em número de mortes no Brasil. Então, esse projeto visa aumentar um monitoramento clínico de indivíduos com CD4 abaixo de 200 células que são atendidos nas clínicas de saúde pública na região metropolitana empobrecida do Rio de Janeiro. E essa intervenção inclui o tratamento da infecção latente por tuberculose, a ampliação do uso do Bactrim e a identificação de casos de criptococose em indivíduos com CD4 abaixo de 100 células, usando a estratégia do laboratório Reflexo. Ou seja, todos os indivíduos que foram identificados, quer dizer, nós temos no Brasil uma rede de laboratórios nacionais espalhada pelo país inteiro, aonde são realizados os exames de CD4 e carga viral de todos os pacientes atendidos na rede pública no Brasil, que são a grande maioria dos pacientes vivendo com HIV/AIDS no nosso país. Então, essa estratégia desse projeto testou esses pacientes cujo CD4 foi realizado nesses laboratórios de referência e que foi identificado um CD4 abaixo de 100 células, foi feita, então, essa estratégia reflexa de testagem de antígeno criptocócico. E esse resultado do antígeno foi, então, passado para esses serviços, para que esses indivíduos pudessem ser chamados para imediato tratamento. Então, nós conseguimos, como vocês podem ver nesse slide, nós avaliamos em torno de 1.500 indivíduos entre junho de 19 e setembro de 2021, incluindo todo o período da pandemia de Covid, e nós fomos capazes de diagnosticar 65 indivíduos com antigenemia positiva para criptococo, com uma prevalência global de 4,5%. E esses pacientes, então, foram chamados para o atendimento clínico e os desdobramentos, diagnóstico da meningite criptocócica e posterior hospitalização para tratamento desses pacientes com meningite, hospitalização para tratamento com anfotericina B. Nós pretendemos, com os resultados desse projeto, ver a possível incorporação dessa estratégia de laboratório reflexa para diagnóstico precoce dos indivíduos com doença criptocócica. Esse mapinha mostra, nesses quadradinhos amarelos, o número de laboratórios no país que faz testagem de carga viral e CD4 e que nós podemos instalar essa testagem reflexa para antigenemia criptocócica, tentando num esforço de antecipar o diagnóstico dessa doença tão grave. Seguindo, então, nós vamos falar rapidamente sobre a histoplasmose. Estimativas recentes mostram que a histoplasmose equivale em incidência na nossa região a uma incidência e gravidade comparadas à tuberculose na América Latina. Então, é muito importante que a gente dê muita atenção ao diagnóstico da histoplasmose, que pode ser, muitas vezes, difícil e confundido com a apresentação da tuberculose, dada a semelhança dos sinais e sintomas, que podem ser indistinguíveis de outras infecções, tais como a tuberculose disseminada. Infelizmente, apesar dos avanços tecnológicos da melhora de diagnóstico, esse diagnóstico de histoplasmose não é amplamente disponível, sendo que a metodologia adequada é o diagnóstico molecular e que deve ser adotado, então, para o diagnóstico precoce de histoplasmose. Os guidelines da OMS são baseados numa abordagem de saúde pública e integram as diferentes abordagens que são necessárias para um indivíduo diagnosticado com histoplasmose. Antes de tudo, o diagnóstico deve ser prontamente pensado, né, num paciente com doença disseminada. Na nossa região, o diagnóstico de histoplasmose é um diagnóstico mandatório de ser pensado e a testagem feita o mais prontamente possível. Também a importância extrema do início do tratamento antirretroviral para pacientes com histoplasmose, independente da situação, mesmo com infecção de histoplasmose ativa, é extremamente importante não só o diagnóstico e o pronto início da terapia antifúngica, mas também o início pronto, rápido da terapia antirretroviral. Recentemente, foram pensadas, então, caminhando para a finalização aqui, quais seriam os maiores desafios e os maiores espaços para desenvolvimento de pesquisa para o melhor avanço dessa situação da doença tardia e do diagnóstico tardio e da mortalidade precoce. E questões importantes são como os países podem adaptar os seus sistemas de saúde para incorporar esse pacote de diagnóstico da doença avançada, melhorando o cuidado para esses indivíduos, como esses novos diagnósticos podem, de fato, ser incorporados dentro do que a gente pode ofertar, como a gente pode avançar no rápido início da terapia antirretroviral, mesmo para doentes com doença, mesmo para indivíduos com doença avançada pelo HIV, e, de forma importante, apesar de que temos claramente a indicação do início da terapia antirretroviral, independente do resultado do CD4, temos que manter de forma importante e crítica a realização do teste de CD4, que é, sim, a porta para a identificação desses pacientes com doença mais avançada, para que estes possam ser prontamente abordados com relação ao início das profilaxias e a observação clínica mais intensiva, dada a gravidade do desenvolvimento de complicações infecciosas que tem uma alta taxa de mortalidade associada. Então, é muito importante a gente separar as duas questões. A gente deve, sim, iniciar prontamente o tratamento antirretroviral, mas devemos, sim, fazer a solicitação do exame de CD4, que é fundamental para que essas condutas outras possam ser realizadas. Outras questões de pesquisa também foram avaliadas pela rede IDEA, mostrando também que a importância da realização de pesquisa operacional, que na nossa região existe, mas precisa ser muito ampliada, principalmente no foco da doença avançada pelo HIV, para que a gente possa identificar os principais gargalos na implementação dessas políticas já definidas. Só para finalizar, embora a gente perfeitamente entenda e saiba tudo o que a gente precisa fazer para que a gente possa melhorar o diagnóstico da doença avançada pelo HIV com relação à estrutura de diagnóstico precoce, início da terapia antirretroviral, diagnóstico e tratamento das doenças oportunistas, nada vai avançar sem que nós possamos, de fato, combater o estigma e a discriminação que os indivíduos sofrem com relação ao HIV, em relação a serem parte de uma população mais vulnerável, e enquanto nós não conseguirmos, de fato, aprimorar, diminuir esse estigma e a discriminação nos serviços, nós vamos continuar tendo enorme dificuldade dessas pessoas chegarem e serem beneficiadas com o que de melhor existe disponível para elas. Gostaria de agradecer as várias pessoas que me ajudaram nessa apresentação. Muito obrigada.
Thank you, Beatriz, and great to hear that overview. Thank you for leading off this workshop. We're running a little behind on time, so without further ado, let me introduce our next speaker, Dr. Matthew Natcher. He's a physician scientist with training in research, public health, and tropical medicine. He's a professor of public health at the University of French Guiana and currently the director of the Clinical Investigation Center in CERN. He has been the AIDS program chair for French Guiana since 2004 and has worked on all aspects of HIV and is a good friend and colleague working in the fungal disease space. So Matthew, over to you. Merci.
Thank you, Tom. Can you hear me?
Yes, we can.
Can you see my slides?
We can, but you should go to the top and you are in the mode where we see both slides.
Oh.
So I think if you switch screens on the display settings, you see in the top where it says display, keep going over to the left of the thing, it will say like display, and you can switch.
Yeah, presenter.
Yeah, try to swap
like
it.
Is that okay?
That's it. That's perfect. Thank you.
Okay, I'll try to catch up. So I'm going to
no
talk about the burden of fungal diseases in persons with advanced HIV in Latin America. So Beatrice showed some slides about HIV. Just be summarized, it's only about 60% of people on ARVs, and as she said, still a lot of people coming late with advanced HIV. The number of people living with HIV increases, and deaths are kind of not really decreasing spectacularly. And this, most people are still in the young age groups, so this has an impact on life expectancy. So this is the slide that I would like to start on. It's data from our HIV cohort. It's about over 2,000 patients, and this is these are the top opportunistic infections in HIV patients in French Guiana. So French Guiana is between Brazil, Amapá, and Suriname. So it's Amazonian ecology, and this is what we get. So the number one by far is histoplasmosis, and among the top 5 opportunistic infections, we have 4 fungal pathogens, and this is French Guiana is a French territory. So the cascade of care in 2019 was 90 by 91 by 94, and over the period where we had this data, it was the first 90, maybe it was 80, 91, 90. So even with a good cascade of care, the patients that come with advanced HIV, that are diagnosed with advanced HIV, still contribute most of these OIs. And with some friends from different countries in Latin America, we tried to see, well, what does that mean in terms of mortality? And with a quick back of the envelope calculation, our incidence was 1.5 per 100 person years. When you factor that with the HIV prevalence and looking at malaria, which when we went to the American Society of Tropical Medicine, everything is about malaria, where you can't even see deaths from malaria in South America. And the message with this crude calculation was that histoplasmosis was on par with TB in terms of number of deaths in HIV patients. So to be more precise, because all countries do not have the same epidemiology, we tried with Antoine and Tom and Orion to be more precise, and these are the maps of the prevalence and incidence, and you see that Central America and the Amazon region seem to have very high incidences. Brazil here is in pink, but Brazil is a huge country with a very different ecosystems. And when the study was published in 2019, what you see is a gradient with the highest prevalences in the northern parts of Brazil. There were no data from the northern states of Amapá, Amazonas, Pará, but still it shows that it's above 2/3 in these regions. 2/3 of patients with HIV patients with fever admitted had histoplasmosis. So to summarize the findings, about 43%, 9 of 21 Latin American countries, had a number of histoplasmosis cases that was on par or greater than TB cases. And in terms of, so this is the median scenario, and we take 50% symptomatic, and then we took a 40% fatality rate. And when you take this scenario, you have 2/3 of countries, 14 out of 21, where the number of deaths from histo is on par or greater than TB each year. So I think it was Alessandro Pascalotto who wrote an editorial saying histoplasmosis dethrones tuberculosis, which is a nice way to encapsulate the message. And the sad thing is that often it's because diagnosis is not done or is too late or people are not aware. And these are slides from, this is a paper from Diego Caceres from Colombia, where they showed that a training program and diagnostic tools had an impact on mortality. This is our, on the right, we see that in fact mortality went from 40%, the historical rate, to now 4%. So it was divided by 4. So I guess part of this is the increase in the ARV coverage, but not only. It's been years of histoplasmosis paranoia, where we're very, very suspicious of it and look for it, although we don't have antigen detection tests. And this recent study from Guatemala also found that a program where diagnosis of histoplasmosis, TB, cryptococcosis, and other microbacteria led to a reduction, a 7% reduction of OI mortality per year, which still seems low, because we observed, like in French Guiana, a twofold reduction every 5 years. So perhaps if every year 7%, this will lead to the same results. It would be interesting to follow. And this slide from the same paper is very interesting, because it was something we were also thinking. When you have a patient and you're not sure, does he have TB or does he have histo, which one should you treat first? And we tend to treat histo first, because the severe cases die very quickly in what looks like a septic shock. And this slide shows here that in purple, you have histoplasmosis deaths. In blue, you have TB deaths. So indeed, histoplasmosis deaths die quicker, and same for crypto deaths. So interesting paper, and shows also the importance of having a rapid diagnosis and effective drugs. This is from our center, where we see the different invasive fungal diseases. So again, histoplasmosis is the #1. Then we see cryptococcal meningitis. The red line there, or maroon line, is in fact patients from the ICD classification of cryptococcal meningitis. That was the final diagnosis. But when we looked at the lab, we found far more cases of crypto-positive patients, and looking at the files, we didn't find a diagnosis. Some of these patients most of them were treated. So actually, we probably have a lot more crypto than we think. And again, a lot of so the overall incidence rate per 100-person year is 2.5 invasive fungal infections per 100-person years. That's the rate, despite the pretty good cascade of care that we have. So all these new patients showing up with advanced HIV disease often have invasive. So these are the species I'll pass through to get. And I would like to say, like, aspergillosis, 0 cases in HIV patients, and I don't think is that because we have mycologists, so they know what it is, but we don't see it much in our cohort. So other fungi, so this is a map from a paper from Arnaldo Colombo and Coccidiomicrosis in Latin America. There was a review paper. It's not very frequent, apparently 136 cases in 30 years. So it's maybe not a major problem, at least from our point of view. And Coccidiomicrosis, very focused areas where you have some endemicity. but not so much. And I would like to go back to the slide that I showed. So in red here, you see fungal diseases, and they're way up top. And if you count it different, as I said, top 5 OIs, 4 fungal pathogens, 78.9, nearly 80% of the top 5 are fungal pathogens, and nearly 60% of all OIs are fungal pathogens. So fungi are really, I would say, the biggest problem in our setting now, it's really important to this. So this seminar is really important because we really need to get better at this if we want to reduce mortality. And half a century ago, there was this paper, the medical mycological iceberg, and the introduction, it was by Dr. Agello, is still so true today, and it talks about the iceberg. And I think that half a century this was true. This is still true, but I think tools are on the way to have earlier diagnosis. I know that despite the fact that the guidelines for histo came at the worst possible moment in April 2020 when COVID was distracting everyone, I heard that still things are going on, and this seminar is a proof, and that things are moving along for drugs, for diagnostic tests, for awareness. And so I'm very happy to be here and to give my talk. I hope I'm in time, Tom, and that's it.
Fantastic, Matthew. Appreciate you making up some time for us today, and wonderful overview of the problem. And thanks for ending with Libero's famous article that he wrote many years ago. He was, of course, the chief here at the US CDC for a long time in mycology, and really tried to move things forward as we are doing. So thanks for that. It gives me great pleasure to introduce our third speaker in this opening session. Dr. Nathan Ford is a scientific officer, excuse me, with the department. He's also an author, but an officer with the Department of HIV/AIDS in the Global Hepatitis Program at the World Health Organization in Geneva, and head of WHO's Guidelines Review Committee. Prior to joining WHO in 2012, he worked with Médecins Sans Frontières, MSF, for 14 years, supporting HIV programs in a number of countries in Southern Africa and Southeast Asia. He holds a degree in microbiology and virology, a master's in public health and epi, and a PhD in clinical epidemiology. Nathan, over to you. Thank you.
Thank you very much, Tom. And I'm assuming you can see my slides okay?
They look great.
Okay, great. So thank you very much for the kind introduction, and thank you for the invitation to speak today. I'm going to give a more global perspective before we come back to focusing on the region, and I am going to give an overview of WHO's global guidance on advanced HIV disease and disseminated fungal infections. So WHO's guidelines on managing advanced HIV disease were developed in 2017, and some of you assisting in this seminar helped WHO to develop these guidelines. The definition of advanced HIV disease is anyone having a CD4 cell count below 200, or in the absence of CD4, a WHO stage 3 or 4 event. And it's important to stress that this includes both individuals who are starting treatment for the first time, and also those individuals who may have dropped out of care for a number of reasons and are re-engaging in care with a low CD4 count. And WHO defines all children younger than 5 years old as also having advanced HIV disease. So why did we produce these guidelines in 2017? These were produced at a time where the world was shifting towards treating everyone who has a positive HIV diagnosis, irrespective of CD4 count. And there was a movement globally towards assuming that all we needed to do was get more and more people on antiretroviral therapy, and the problem of advanced HIV disease would be solved. But data since that time and around that time demonstrated that, in fact, advanced HIV disease is a persistent problem. And these data from the IDEA Global Cohort Collaboration in 2015, the same time the recommendation to treat all was issued, show that over a third of people who started treatment around that time started with a CD4 cell count below 200, in other words, having advanced HIV disease. This slide just tries to summarize that more recent data shows that the problem has still not gone away. So on the left, we have recent data from Botswana up until 2018, which shows that the prevalence of advanced HIV disease persists at around 17% of individuals presenting for care. And on the right, we have a small data set from the UK showing an increase in patients presenting with advanced HIV disease. This paper compares people presenting in 2019 and people presenting in 2020. And it shows that comparing these two periods, the CD4 cell count of people admitted to hospital fell from 160 cells in 2019 to 60 cells in 2020. And this was associated with service disruptions due to COVID-19, leading to late diagnosis and treatment interruptions. And so this is a trend that needs to be followed very carefully. If we're seeing more advanced HIV disease in a setting like the United Kingdom, we can have confidence, unfortunately, that we're likely to be seeing more advanced HIV disease in many other settings around the world. I'm sorry, I'm going backwards. So it was clear that advanced HIV disease was a persistent problem. And in order to understand what was leading to the main causes of mortality, WHO conducted a systematic review to understand what the main causes of hospital admission and in-hospital mortality were among people with advanced HIV disease. And this review found that tuberculosis, cryptococcal meningitis, and severe bacterial infections were the leading causes of mortality, particularly among adults presenting with, who admitted to hospital. So following this, WHO undertook a systematic review to identify interventions that could be provided as a package to respond to advanced HIV disease as part of a public health approach. And these two studies were identified, REMSTART and Reality. And these are the key components of these two trials showing the major differences. So they were both conducted in Southern Africa. One was conducted with, both conducted in populations with a CD4 less than 200. Reality had to narrow enrollment to 100. And what we can see from this brief summary is that the Reality trial took a prophylaxis-driven approach, whereas the REMSTART trial took a diagnostic-driven approach. And interestingly, both studies showed a near identical reduction in mortality associated with the package of care that was provided. So 27% reduction in the case of Reality and a 28% reduction in the case of REMSTART. So following these, information from these two trials, and no other packages were identified by the systematic review, WHO recommended a package of interventions that includes screening, treatment, and/or prophylaxis for major opportunistic infections, rapid ART initiation, and intensive adherence support for anyone presenting with advanced HIV disease. And this was a strong recommendation based on moderate quality evidence. And this is the summary of what's in the package. It was inspired by both of those randomized trials, Reality and REMSTART, and took components of each, in order to come up with a package that included TB diagnostics, including TB-LAM, cryptococcal antigen testing, prophylaxis, cotrimoxazole, TB preventive treatment, and fluconazole, rapid ART initiation, and intensified adherence support. So those guidelines were issued in 2017, and then in 2018, WHO updated its guidelines for cryptococcal meningitis, and then in 2020, led by PAHO, WHO issued guidance for the diagnosis and management of disseminated histoplasmosis. And then more recently, just earlier this year, WHO took all of these guidelines, advanced HIV disease, the management of cryptococcal meningitis, and the management of disseminated histoplasmosis, and integrated these three guidelines into the consolidated HIV guidelines that were issued in June, and clearly recognized that the management of these conditions should be a core component of any HIV program, and these guidelines are global. So these are recommendations that apply globally. So what's coming up in the future? Well, WHO is working with partners and with country offices to support uptake and implementation of the advanced disease package. We're looking at updating the recommendation for the treatment of cryptococcal meningitis, responding to results of an important trial that were released in July. We're looking at considerations for the management of severe bacterial infections, acknowledging that this is not a simple challenge. We're looking at issuing policy guidance on the management of advanced HIV disease at the hospital level. And we're exploring any regional adaptations that may be needed to the package of care for advanced HIV disease. And with that, I would like to close my presentation and thank you all for your attention. And I'm looking forward to the rest of this symposium. Thank you very much.
Thank you, Nathan, and appreciate the global overview. And I think we've managed to catch up on time, which we will move the discussion. Sorry, I'm hearing some people talk there. We will move the discussion to after the next session where we will focus now on specific country implementation challenges. So I would like to introduce Dr. AJ, and I know I'm going to get his last name wrong, AJ, so I'm sorry, Rangaraj, Dr. AJ Rangaraj at the World Health Organization, also in the Department of HIV and Hepatitis. AJ, over to you to moderate this next session. Thank you.
Thanks very much, Tom. It's really great to be here, and thank you for inviting me to moderate this session. I hope you can all hear me well.
You sound great.
Okay, sounds good. Thank you. So this session really we're moving into talking about specific country experiences, and we have three really great speakers with us today. It's really a pleasure to be able to introduce them. We will be having Eduardo Aratun, who is from Hospital General San Juan de Dios in Guatemala. Then Nilesh Govinder from NICD South Africa, and then Paul Niasulu from Malawi, the DHA from Malawi. So we will begin with Eduardo, and he's the medical director at Clínica Familiar Luis Angel Garcia, an HIV clinic in Guatemala City. He earned his medical degree in Guatemala and specialized in infectious disease and clinical mycology at Stanford University. He has over 30 years of experience in fungal diseases affecting HIV patients in the region. So I'd like to invite him to speak now. Thank you.
Okay. Muchas gracias por la introducción. No me deja meterme al video, así que voy a tener que extremar la pantalla.
Por favor, Julia, si puedes permitirle compartir pantalla al doctor Aratun.
Doctor Erasmus, usted entró como Nadia Medina, Nata Medina.
Yes.
Ah, ok, ya está como co-host.
No, I have it. Okay, thank you.
Creo que hay
Please
dos,
go ahead.
Nadia, Julia.
Sí, ya está.
Right. Can you see my slides?
Yes, we can see it. Just maybe put it into presentation mode so we can
Right.
just check and see. Yep, that's perfect. Sounds good.
Okay.
Thank you.
Thank you very much. Sorry for the delay. I work, as you said, I work in Guatemala, and I at the Clínica Familiar Luis Ángel Garcia, and we implemented a national network of 13 healthcare facilities for opportunistic infection screening, and we follow WHO recommendations to provide access to diagnosis and treatment for patients living with HIV. And we also have a system of active finding of opportunistic infection cases. And we allow patients without opportunistic infections a rapid start of antiretrovirals through this method. And what we did is that these are the clinic, all the HIV clinics in the region. And we included all of them except 2 that declined the invitation to work with us. And we asked them to provide us with all information of the patients that they had and send us samples from these patients. First, there was a training for the physicians, and we started a laboratory, and it was a hub in which everybody sent through a courier all the samples to the laboratory. And the patients that we included were new HIV cases, also patients that abandoned treatment for more than 90 days and looking for care, and also patients that were taking antiretrovirals and also were having symptoms or were looking for any type of care. And the strategy was to screen all with or without CD4 counts, because we have about 30% of 25% of the people in our system that do not have CD4 counts. And so regardless of the CD4 counts, we included them, and we followed them for 180 days follow-up. And the results were that the 3 cohorts, 2017, 2018, 2019, with around 6,000 patients. The primary analysis of 1917 and 18 is what we're going to present in this presentation. I want to clarify something. Guatemala, according to UNAIDS, 46% of the patients present for the first time with advanced HIV. And in our study, we found that this number is higher. It is 52%. So it makes Guatemala the country, according to this report from UNAIDS, where patients arrive later during the disease. And that's because we don't have a strong program to screen patients. We also included 385 patients from all these 6,000 patients, and with opportunistic infections. And what we found is that the overall incidence of tuberculosis was 7.1%. Non-tuberculous mycobacteria were 1.1%, histoplasmosis 7.9%, cryptococcosis 4.8%. The same as Dr. Natcher, we found that histoplasmosis is higher than tuberculosis in terms of the overall incidence. When we screened them by intervals of CD4 counts, we found that when their CD4 count was less than 50, tuberculosis was found in 11%, non-tuberculous mycobacterium 2.4%, Histoplasmosis was 19%, almost 20% of the patients, and cryptococcosis was 14%. So this is a little bit different than what Dr. Natcher presented, because we find we have a higher incidence of cryptococcosis than he did. And of course, we only compare these diseases. And when the interval was 50 to 99, we found that tuberculosis was still present, but the histoplasmosis started to go down. It still was 7%, and cryptococcosis was 7.4%. Then in the 100 to 199 group, the numbers were even lower for the fungal diseases, and tuberculosis was present. From 200 to 350, we found that there was a total incidence of opportunistic infections of 6.8%. So a little bit different than what the histoplasmosis guides tell us. We decided to screen all the patients, and from now on, which are at least less than 350 CD4 counts, and that was because we would have been missing some opportunistic infections if we didn't do it that way. In this slide, we found co-infections. So in order to find the co-infections, what we did was to try to screen for every single opportunistic infection. Even if one of them was positive, we would still do the second test. For example, if histoplasmosis was positive, we encouraged the doctors to send samples for tuberculosis too, so that we could find if they had co-infections. And we were not surprised, because we had the data before, that 8.1% of our patients, and a total number of 31 patients, had co-infections. The more common one, which is almost the same as histoplasmosis, was cryptococcosis plus histoplasmosis. And then histoplasmosis plus tuberculosis was the second one in 32% of the cases. And then crypto and TB was 12%, cryptococcus was 6%, tuberculosis, non-tuberculous mycobacteria was 6.5%. So sorry, 6.5%. And this is with tuberculosis and histoplasmosis. The same numbers was for the two co-infections. So the first two diagnosis of cryptococcosis, histoplasmosis, and histoplasmosis tuberculosis was, I'm almost sure, I'm a clinician, so I usually try to examine the patient very carefully, but we have found that no matter what we did, it was impossible to figure out if the patients really had a co-infection or not. So without the screening, I'm sure we would never find out that patients were co-infected. So this speaks strongly for doing the testing, even if you don't suspect that the patients have a certain disease. And this is more important with cryptococcosis, when you can find the patients before they have symptoms. So we found this at the beginning of this century, really. And we decided to try to figure out how to solve the problem. So we went to CDC, and in 2009, for the first time, the urine antigen for histoplasmosis was available to us. And we proved that we really had a lot of cases. So after that, different countries decided to adopt the same strategy, and it was first gone to Colombia and then to different countries in Latin America, as you can see in this map. So the challenges that we find is to have a laboratory test facilities in all these clinics, which are very humble clinics, very poor clinics. and to have a urine antigen that requires some degree of expertise for the ELISA that needs to be done, and to have gene expert machines in these places. So that's why we created a central lab to facilitate this. And then what really is the main point of this talk, drug-drug interactions are very common, and with these medications that we use, especially when we use azoles, antiretrovirals, and especially with rifampin in the tuberculosis treatment. And this is the frequency of histoplasma in Latin America. And as you can see, there are different numbers. For example, in Argentina, 9% of TB and histoplasmosis. Then Diego Cáceres in this study in Colombia found 35%. Our own study before we did we analyzed these 3 cohorts was 26%. So it is not an uncommon occurrence in Latin America. The problem is that how to manage these co-infections. So as we said, we follow all the PAHO guidelines to treatment in advanced disease and histoplasmosis. And when the patients are co-infected with histoplasmosis, tuberculosis, cryptococcosis, and they're taken antiretrovirals, we have serious problems. For example, we know, well, we don't use darunavir. We still use darunavir, and with rifampicin, what darunavir is that it increases the levels of rifampicin, and rifampicin decreases the levels of darunavir. When we combine itraconazole, for example, with efavirenz, we find that itraconazole is diminished and the efavirenz goes up. When we combine it with INA, with the isoniazid, we find that itraconazole levels go down, maravir goes down with itraconazole, and then protease inhibitors are just, they go up and they are just contraindicated. And rifampicin, what it does is that diminishes the levels of itraconazole, and rifampicin goes up. If itraconazole is diminished, and we know that we have problems with the viability of itraconazole when it is taken by mouth, especially when the pH of the stomach is not very acid, we know that we're going to get into trouble with rifampicin. So, and this is the only drug that we have we don't have any of the other rifamycins. And so we have thought of different strategies. We don't find in the guidelines and the histoplasmosis guidelines, really you don't find an answer to these questions. The problem is just exposed in the guidelines, but there is no really answer to it. So what we decided to do was, for example, if the patient had histoplasmosis and tuberculosis, we would try to start with amphotericin B, which has no problems with the tuberculosis treatment, and the tuberculosis treatment, depending where the infections were, especially if the patient had tuberculosis meningitis, which we find a few of them, then we would know that it's very important to start with the tuberculosis treatment at the same time. And if we are afraid that this is not going to work, and when we have to switch them to itraconazole, for example, then we try to prolong the amphotericin B. Sometimes we give it 2 or 3 times a week as a maintenance for the histoplasmosis, while we try to make sure that the tuberculosis treatment is working as well. And we don't have ways to measure the different drugs. So what we needed to do is to try to get some method to do it. And but I'm not sure this is going to really work as well, because it varies a lot from with different drugs that the patients are taking. And something else we found is that if we monitor the levels of histoplasma antigen in urine, what we do is that, although it's not certain what we're doing, we know that in almost all of our patients, when we follow the levels of antigen in urine, it decreases with time. So if we see that the levels are decreasing, we assume that the patient probably is getting well treated for histoplasmosis, and that's an indirect way to try to figure out what's going on. Something else we have found, because we see a lot of histoplasmosis, is that the patient has a renal failure. Sometimes the antigen doesn't get excreted in urine as readily as patients with normal renal function. And sometimes we have to do the diagnosis by culture or bone marrow in these patients, and the antigen is negative in the urine. And in the future, probably the problem is going to get worse, because I think the tendency is that the histoplasmosis is going to be diagnosed through lateral flow assays, and that might pose a different problem when we try to figure out if the levels of antigen are decreasing or not. And tomorrow, I think Narda Medina from our group is going to talk about new methods of artificial intelligence to try to quantify the different antigens in lateral flow. And so probably that could be an answer that we'll have in the future to try to follow the patients and make sure that they are doing okay. And we know on the positive side that universal screening for fungal diseases has decreased the mortality in our patients. Dr. Natcher referred to a paper in which the numbers decreased by 7% from one year to the other. Unfortunately, we have data from the COVID experience at this time. And in the first 8 months of the pandemic, our mortality increased by 8%, and the screening of patients and patients that we could find with new infections was decreased for about 24%. So probably even with all these efforts that we've been trying to do, the COVID pandemic is going to make us go back from what we had before. And I hope this is not the case, but we're trying to deliver medications at home. We're trying to send them to see them by telemedicine, but it is very difficult for some people to have intelligent phones and try to get them to follow the telemedicine and make sure that they're taking the medications at a distance. Is not the ideal circumstances in this poor country. So we're still trying to figure out ways to cope with the pandemic and the threat that it has posed to us. Thank you very much for your attention, and this is all I have to do.
Thanks so much for the presentation. I think it was really interesting, and also I think quite notable. Like, you provided some clinical caveats in terms of difficulties in diagnosis and those with undergoing dialysis, and I think those are important issues that could further make diagnosing histoplasmosis a challenge. So thanks very much. Just to sort of keep with time, I think we'll move over to the next speaker who we have with us today, and I would like to invite Nilesh Govinder, who is a center head at the National Institute for Communicable Disease in Johannesburg, South Africa. He is a professor at Wits University with honorary affiliations to the University of Cape Town, the University of Exeter, and St. George's University in London. He led implementation of a national reflex lab-based cryptococcal antigen screening program in South Africa. So without further ado, Nilesh, over to you.
Thanks, Ajay. I don't seem to be able to share my video for some reason, but thank you very much for the invitation.
I think they'll enable it in a few seconds, so you can just maybe try again. You can start, but just try again in a few.
Can you try again, please? Thank you.
There we go. Thanks so much. Can you see me?
The screen is blacked out.
Oh, I have no idea why.
Maybe just stop and restart. I think it should be fine.
Ajay. I see Julia. You can see
Yeah.
the presentation. Maybe it's you, Ajay. You're receiving a little late.
I can see the presentation. He was asking about his video.
Sorry.
Yeah.
No problem. Please go ahead, Nilesh. We'll try to sort out the video as we
Okay. Thanks, Ajay. I'll just leave my video on and hopefully that'll be sorted out. Thank you very much again for the opportunity to present. So I'm Nilesh Govan and I'm based in Johannesburg, South Africa. So I'm really glad to be able to join you, even though we are having an outbreak of the Omicron variant. I'm just delighted to be able to join you. So I'm going to talk to you about cryptoantigen screening in South Africa. And as we know, cryptoantigen screening has really transformed the landscape of HIV-associated cryptococcal disease from a disease that was previously diagnosed only when a patient was severely ill with life-threatening meningitis to a much earlier diagnosis and life-saving preemptive treatment. In the real world, unfortunately, even countries like South Africa with a national screening program have challenges, and I'll tell you about some of those shortly. These are my conflicts of interest, just to point out on the world map where South Africa is located. So Cryptococcus, as we know, has a large polysaccharide capsule, and unique components of this capsule can be accurately and rapidly detected by antigen tests. A simple cryptoantigen test really catalyzed action and opened up the possibility of large-scale screening programs, which then had the potential to save thousands of lives. I think most people understand the basic principles around screening, in that antigenemia could be found weeks before symptoms of meningitis occur, and preemptive treatment, of course, is then given to people who test positive for cryptoantigenemia. So this screen and treat intervention has been implemented in many countries across the world since the WHO recommended crypto screening as a key part of the package of care. And also when a large clinical trial, which Nathan mentioned, demonstrated a sizable reduction in mortality. To give you a brief history of the National Cryptoantigen Screening Program in South Africa. So prior to the WHO cryptococcal disease guidelines published in 2018, and even prior to the AHD guidelines published in 2017, rapid advice was issued in December 2011, when the WHO recommended, with a low quality of evidence, it was a conditional recommendation, but they did recommend cryptoantigen screening for patients with severe immunosuppression with a CD4 count below 100. South Africa's National Strategic Plan for HIV, TB, and STIs was published shortly thereafter and included cryptoantigen screening. So we were fortunate that policymakers saw the potential of this intervention. And so that allowed us to set up a phase 1 screening pilot in 4 districts in one of our most populated provinces and a neighboring province. By mid-2014, we'd completed evaluation of a provider-initiated screening program, and we'd also compared provider-initiated screening to reflex screening and demonstrated the benefit of reflex screening over provider screening. So just to summarize, reflex laboratory screening is essentially where patients have blood drawn for a CD4 test, and if that CD4 count is below a specified threshold, the cryptoantigen test is automatically done. And of course, then patients with cryptoantigen positive then receive preemptive treatment at the next follow-up visit. South Africa has a large network of CD4 laboratories, We've got the largest number of people with HIV in the world. There are more than 7 million people, and our CD4's testing program tests around 3 to 4 million samples every year. And of those samples, about 10% have a CD4 count below 100. So that's about 300,000 or 400,000 samples per year, and these samples are processed in large laboratories, which really have automated systems. So following on the costing work, screening was then included in our national HIV guideline and then in various other guidance documents. And so by April 2016, we'd commenced a national rollout of cryptoantigen screening, and that was completed by October 2016, so that all CD4 laboratories were performing cryptoantigen screening, covering all of our 52 districts. Here are some data just to summarize our screening statistics between Feb 2017 and September 2021. So over that period, more than 1.2 million cryptoantigen reflex tests have been run, and there have been more than 75,000 positive cryptoantigen tests. In terms of patient-level data, more than 1 million eligible patients have been screened, with a 99% coverage in terms of eligible patients being screened, and more than 64,000 positive patients have been identified. So we've analyzed these data over the last 4 years, and we've noted that there are cryptoantigenemia hotspots across the country where extra resources really should be allocated to ensure that people with advanced HIV disease access HIV care earlier, and also that those who screen cryptoantigen positive are managed appropriately. We've noted that 2 provinces, Gauteng and KwaZulu-Natal, contribute more than half of the cryptoantigen positive cases, reflecting to some extent the burden of advanced HIV disease in these provinces. And KwaZulu-Natal, this province on the east here, has a prevalence which is almost 40% higher than the national average. And this may be related to a lower median CD4 count at CRAG screening, but possibly also other ecological factors. We've also been looking at time series analyses of our national cryptoantigen screening data. So these graphs show you the weekly number of tests over time between 2017 and 2021. And what you can see here is a gradual decline in the number of screening blood cryptoantigen tests, both at clinics and at hospitals. We split our analyses up by clinics and hospitals. Our national screening program obviously covers both types of facilities, but obviously the level of care and the issues are very different at clinics and hospitals. And this decline, to some extent, reflects a similar decline in samples with a CD4 count less than 100. So this was an interrupted time series analysis. We looked at the impact of the COVID pandemic, and of course the COVID restrictions, the quite severe restrictions that were implemented in 2020. And you can see that at clinic level, we saw a reduction in CRAG screening, but not as marked at hospitals. When one looks at the trends in positive cryptoantigen tests, we see a gradual but less steep decline in the weekly positive CRAG tests. And then following on the COVID restrictions, we see a substantial drop at clinics, but not so much at hospitals. Cryptoscreening, of course, the point of cryptoscreening is to try to prevent cryptomeningitis and deaths. But unfortunately, we know that this potential is not always realized for some of the reasons shown on the slide. For instance, people with a positive test, of course, must receive preemptive fluconazole. but through a large cohort study that we just completed, we found that only approximately half of patients who test positive receive preemptive fluconazole, mostly because they don't return to clinic after being screened. And so we've got this study called CASNet, which is really assessing treatment and clinical outcomes of patients who are CRAG positive in 27 sub-districts across the country. Unfortunately, we don't have an electronic health system in terms of hospital and clinic data. And so CASNet has had to use more manual systems in terms of data collection. So we've imaged paper charts and abstracted data directly from charts from these 3,000 patients. A major issue is that laboratory test results don't get to the clinic or to the bedside. So what we've done is we've designed these results for action reports, which provide line lists of patient level CRAG positive results at a facility or district level. And so that delivers results, aggregate data directly to clinicians and also to facility managers. And that helps to facilitate patient follow-up and treatment. That's available daily or weekly. And the goal, of course, is to ensure that no patients fall through the cracks and that everyone receives treatment. I'm going to just end by saying that even though the WHO currently recommends screening for everyone with advanced HIV disease, our program still focuses on people with a CD4 count less than 100. We undertook a survey last year for a month. We expanded our national screening to include all people with advanced HIV disease. And we looked at the prevalence and we found that we tested approximately 40,000 people in a month. You can see that the prevalence of antigenemia is, of course, highest when the CD4 count category is low, and that declines as the CD4 category increases. We found that if we were to increase our threshold for screening to less than 200 instead of less than 100, we would increase our case detection by about 35%. So just in summary, reflex screening has been successfully integrated into our national HIV program, but there's still missed opportunities. Reflex screening, as I just pointed out, excludes people with a CD4 count between 100 to 200. The pandemic restrictions really have taken us a step back, and far too few people with a positive cryptoantigen test are managed appropriately. So just some acknowledgements to my team and our funders, and a particular acknowledgement to my colleagues at CDC and Tom Chiller in particular, who I've worked with for many, many years on cryptoantigen screening. Thanks very much.
Thanks so much, Nilesh. I think that was really it's a really important example as to how well potentially CRAG can be deployed to identify cases of cryptococcal meningitis. And we will take questions after the next presentation. So I'm just going to introduce our next speaker, and we have Paul Nisulu, who is a public health practitioner specialized in health systems management and earned an MPH from the University of Malawi College of Medicine. He is a practicing HIV management clinician for 12 years and a researcher. He currently works as a HIV care and treatment program officer responsible for advanced HIV disease management in the Department of HIV, AIDS, and Viral Hepatitis within the Malawi Ministry of Health. So Paul, welcome, and look forward to your presentations. Thank you.
Hello, everyone.
Please go ahead and bring up your presentation. Yeah, perfect. Thank you.
Good. All right, so I am Paul Nyasuru, as I've been introduced already. I am quite delighted that I'm participating in this conference, And I believe I'm going to learn a lot in terms of advanced HIV disease management. So my presentation is mainly to share with you the experience for Malawi, how we have implemented CRAG screening as well as urine LF-LAM. So firstly, I'll take you through the HIV epidemiology for Malawi. This is mainly based from the spectrum results for this year, such that we estimate to have a total of 19 million people in the country, and 987,000 of them are people that are living with HIV, which brings the HIV prevalence to 8.5%. And a higher proportion is amongst females compared to males. And the annual HIV incidence is at 0.11%, and the AIDS deaths is at 10,800 deaths in a year. Also to share with you the performance of Malawi in terms of the fast track targets over the 395s under UNAIDS. We had set a target for June 2025, such that we should reach 95, 97, and the last one to be 95%. And we set quarterly targets for the 395s to help us track ourselves. So as end of June 2021, as you can see on the right side, our performance is at 97, 92, and 94, which shows that we are indeed on track to achieve these 395s. And also to highlight with you is the decreasing trend in the new infections as well as AIDS-related deaths. From the two graphs, you can see the narrowing between the new infections and the AIDS deaths. The gap that is there is narrowing from 2010 going towards 2020. And we hope to further narrow the gap towards 2025 as we are reaching 2030, where we aim to eliminate HIV as a pandemic in the country. But of note is that there is a decreasing trend mainly for the AIDS-related deaths over the past years. So advanced HIV disease, it's a prevalent condition amongst patients that are on ART. And the prevalence, of course, has been quite promising with the introduction of antiretrovirals. Over the period from 2008 up to 2021, you can appreciate that the trend has been decreasing from 72% in 2008 and has gone down to 41%, mainly for those patients that have got a CD4 less than 200 amongst those already on ART shown on the green bars. So this is actually a promising intervention that we are doing, and the country wants to scale up to address the challenge that we have. So to address these AIDS deaths, which mainly come because of tuberculosis and Cryptococcal Meningitis, as encompassing a larger proportion of deaths, we introduced the use of urine LF-LAM to identify disseminated TB, and also to use a CRAG using various samples in order to identify cryptococcal infections. And we introduced this in the 2018 guideline following the release of the WHO guideline. And we had integrated it into the HIV treatment guidelines so that the single document should be easily addressed by all the health providers. And within the document, we had included the eligibility criteria to access the screening test and the treatment options are mainly for Cryptococcal meningitis, the 3 options that WHO had recommended and have to be scaled up. So as a country, we agreed to implement it in a phased manner. This was mainly because of the availability of commodities to be distributed across the country. So we had started with 108 sites in 2019, and we were using a hub and spoke model, and with the availability of more screening tests, then we scaled up to 152 facilities across the country. We have a total of 764 ART facilities across the country. So as you can see, the sites that are offering advanced HIV disease indicated in the map on the right side. Before a site is considered as a AHD site, we conduct a site assessment in order to see the treatment capacity and also the screening or diagnostic capacity before we provide those services. Over the period, we have been building the capacity of these providers using the facilitator-led trainings. And we have a national curriculum that have got 14 modules, which includes practical sessions. The clinical practical sessions are actually differentiated according to the facility level. For those that are coming from tertiary or referral facilities, they undergo practical sessions of doing lumbar puncture and administration of liposomal amphotericin B. And for those that are coming from peripheral facilities, they go through case studies and sample collection practical sessions. And over the period, we have trained 3,500 providers across the country. Our package, it really matches with the WHO package, such that we have the diagnostic package where we use CD4 testing to identify advanced HIV disease immunologically, but providers also conduct a clinical identification of advanced HIV disease, mainly from the sites that do not have the CD4 machines. And once that is done, we conduct a reflex testing using serum crack. And once it is positive, a patient is supposed to be conducted a lumbar puncture so that we do a CSF crack and other tests on the CSF. Another reflex test is the urine LF-LAM for TB diagnosis. And once they are diagnosed, the other investigations are conducted like a gene expert in order to rule out resistant TB. We've got a number of preventive packages that are provided, and for Cryptococcal meningitis treatment, we have got the 3 medications and that are included within the 3 options that are recommended. For TB treatment, we follow the national guidelines that is available. In terms of ART initiation, we follow the test and treat policy. And amongst the ART cohort, 3/4 of them are on dolutegravir-based regimens, which is a more potent regimen as well. We also conduct ART monitoring using viral load monitoring to identify resistant viruses. We also use genotype testing. We also conduct genotype testing so that we identify resistance and provide correct treatment for these patients. I want to briefly share with you the performance that Malawi has experienced using these 3 screening tests over the period from July 2020 to June 2021. In terms of CD4, we have been testing patients, those that were eligible, and over that 1-year period, we've tested 29,139 patients, and of them, 24% were having CD4 less than 200. But over that period, we can see an increasing trend in the quarterly tests that were conducted, mainly because of the increased access to the test, and also providers had appreciated the results and the benefit of conducting this advanced HIV disease screening. So in terms of TB lab, we also experienced an increasing trend over the quarterly tests that were done, and out of the 14,927 tests conducted, we had a positivity yield of 20%, which shows that it was a more targeted testing. Likewise, for serum CRAG testing, out of the 12,298 tests, we had a positivity yield of 11%, which is quite significant indeed at the national scale. We do coordinate this provision of advanced HIV disease under the Technical Working Group Subcommittee, which is under the umbrella of the Care and Treatment Technical Working Group. And this subcommittee has been operational since 2019. And within it, we have included civil society organizations so that we could maximize on PLHIV engagement, and the subcommittee meets on a quarterly basis. We also have a national focal person to coordinate the program interventions. We are able to procure the advanced HIV disease commodities using Global Fund grant, which is currently in place, and this actually afforded the country to procure all these optimal treatments and the screening tests to support the HD management. And our distribution is done on a bi-monthly basis in a staggered format, so that we could support the scale up, and we use a push system basing on the data that is captured on a quarterly basis. We have got 5 HD Cascade Indicators that are used, and these indicators are reported on a quarterly basis and further disseminated to the Technical Working Group on a quarterly basis. We use M&D tools that are distributed in the laboratories for those that do testing in the labs, while other facilities, they have improvised the registers that are available in other testing sites, like in the inpatient wards or the ART clinic, so that we could maximize on the testing. And for treatment initiation, we have got also other registers, mainly for Cryptococcal Meningitis. We also have improvised registers available. We intended to scale up HD to 240 additional spoke sites. These sites mainly
Vamos a aumentar esto a más sitios y
the screening of advanced HIV disease using semi-quantitative CD4 tests, so that we can maximize to reach in those facilities that have got poor power facilities. And we also going to use the same urine TB as well as CRAG in these facilities. And our intention is that we should scale up to these facilities in Q1 of 2022, once we receive the commodities that we had procured through Global Fund. And our target is to reach high burden primary health centers those facilities that have got a laboratory assistant or HIV diagnostic assistant, and also those facilities that have got the capacity to refer cases for secondary management are the ones that we are targeting next year. Over the 2-year period, we've been providing advanced HIV disease. We've experienced a number of challenges. I'll briefly share with you the key one that we have noted is the operational challenge to report the whole HD cascade, mainly targeting on the cryptococcal meningitis treatment because the services are provided in separate rooms or locations. Screening is done in one place and the treatment is done in one place. So for us to fully report on the cascade, we are having challenges. But we've got an opportunity that we'll learn, we'll scale up on the lessons that we'll learn from the HD project that is being supported by Bill and Melinda Gates Foundation. And from there are tools that have been developed, and once they are available, we are going to implement that at the national scale from the lessons that we'll learn from there. We also received a recall for infusion filters for liposomal amphotericin B earlier this year. And this has actually disrupted the scale up of using this medication in most of the referral facilities because once we had recorded the filters, we no longer used the commodity. And even though we had mobilized or motivated a number of health providers, but it was not being used. So at the moment, we have used the regulatory authority to expedite the restocking of these filters so that we could resume use of liposomal amphotericin B.
E tentaremos manter o uso da anfotericina B.
Of note mainly is the liposomal amphotericin, which has been quite low.
Infelizmente, o som do orador está muito baixo. Estamos tendo dificuldade de ouvir. Continuaremos interpretando.
More toxic. This is mainly coming from the experience of using deoxycholate, which has got a higher toxicity profile. And even though we introduced this liposomal amphotericin, which is more tolerable, but providers are not flexible to do that. So our plan is to scale up capacity building initiatives, mainly using CPD sessions, so that we could improve competence in administration of liposomal amphotericin B. And also we could maximize on exchange visit programs for these providers to these tertiary or referral hospitals, so that they appreciate that it's able to bring change once amphotericin B has been administered. And another key challenge that we face is a short shelf life of TB lamb, which is usually in a 1-year shelf life. And with the low uptake that we experience, we end up losing most of these commodities without using them. We've experienced a number of challenges that providers, mainly from the lab, are complaining about the quality controls for the LF lamb. And we have referred this issue to the National Reference Laboratory so that they could identify samples that could be used for the external quality control. Lastly, I want to acknowledge contributions or this that are coming in from the Department of HIV and AIDS and Viral Hepatitis. Also, we have the diagnostic department within the ministry who are quite key in providing these services or implementing partners under PEPFAR. Those are coming from MSF, CHAI, and also the CSO community who also contributing to the advanced HIV disease management in the country. Thank you very much. Over to you.
thanks so much for the presentation. I think really offering some really great insights into the enormous progress that Malawi has made in terms of achieving, the 95-95 goals. So I think now we will move into, dealing with some questions that have come in to our speakers. And perhaps I will propose that we begin with a question that has come in to Eduardo. So the question is from Ruben, and the question is if there are cases of Coccidiomicrosis in patients with advanced HIV disease in Guatemala. So Eduardo, feel free to answer.
Can you hear me?
Yes.
Okay. Yes, there are cases of Coccidiomicrosis in Guatemala. As a matter of fact, we have a different strain of Coccidioides in Guatemala. It is the youngest of all, and we have some desertic areas where we have cases, but for some reason we don't find too many cases in patients. We follow up during the past 20 years. We have been following up about 20 patients with Coccidiomicrosis meningitis, and sometimes we get 1 or 2 cases per year of disseminated Coccidiomicrosis, but it's not as common as Histoplasmosis, definitely, or Cryptocurrencies. And the first cases of Coccidiomicrosis were found by the father, Ruben Mayorga, who is in this panel, and he described them in Guatemala. So yes, we do see them from time to time.
Yeah, thanks so much, and I hope, Ruben, that answers your question. The second question actually will be to Nilesh, and the question that's come in is, this is from Jose Vidal. So do you have any estimate of the impact on mortality due to cryptococcosis after implementation of the Reflex strategy in South Africa?
So that's a really great question, Jose. So we've been monitoring in-hospital mortality for cryptococcal meningitis for about 15 or 16 years. And unfortunately, we've not seen a major shift in the mortality. But I think that may be related to the fact that, our in-hospital surveillance system probably includes patients who've been screened as well as those who've not been screened. So those who may be ART naive or, people who've not gone through the screening program. But I think that's a really good point. I mean, we would expect to see a reduction in mortality because in theory, patients who are detected through crypto screening should be identified earlier with a lower mortality, but we haven't got data to back that up yet.
Thanks, Nilesh. And also to note that you also mentioned, during your presentation that it is also the case that you had individuals who were tested, diagnosed, and they never came back for a follow-up. So I think that further adds to the sort of mystery in terms of the numbers, right? I would assume.
Yes, for those who are screened and they're never preemptively treated, I mean, they might as well not have been screened at all because if there's no action taken, then they would be missed in the health system. So, Jay, I think you're completely right there.
Because it only adds to our counting, the total count of cases, but not necessarily in terms of survival. So I think, overall, an excellent question. The next question was from Juan Saavedra. I hope I pronounced your name correctly. The question is, to PAHO and WHO, do you have any programs so that the countries can acquire reagents for rapid diagnosis of TB, cryptococcosis, and histoplasmosis? So,
thank you, Asha. I think Juliana Balini is among the panelists. I don't know if she wants to answer in representation of a strategic fund. If not, she will be presenting this information tomorrow in the first session. Juliana, you are here? So because yes, the strategic funds provide these commodities through strategic fund to PAHO directly to the Ministry of Health. But you need to talk with the Ministry of Health locally. Thank you.
Thanks very much. So the next question that's come in is from Gabriela Santiso. And the question is, when Cryptococcus antigen is positive on screening, do they titrate? And if they do, with what methodology, latex or LFA? Thank you. So this is sort of an open question to all the panelists. Feel free to answer.
Okay, I could mention that in South Africa, we don't, in terms of our reflex screening program, we don't do titration on blood samples. We have looked at whether it would be worthwhile, but I think that manual titration using the standard lateral flow assay would be far too time consuming in our very large program. There are obviously semi-quantitative CRAG assays that are now available, which could substitute for manual CRAG titers. But the question is really, what are the clinical implications of this? We already recommend that everyone who tests CRAG positive should have a lumbar puncture. Yep. And I suppose the semi-quantitative tests or CRAG titers could be useful to sort of risk stratify patients who may need either lumbar puncture or may need enhanced preemptive treatment. But I don't think we're at the point where we've got sufficient evidence to introduce those sorts of tests into a screening program. So we haven't done that yet.
No, that definitely makes sense. I think also from when talking about particularly in LMIC settings, really like time efficiency is sort of key in sort of delivering results, because I think this issue of not following up as well will continue to kind of haunt throughout the care continuum, I would imagine. So just wondering if there's any more questions that we can take. You can post in the Q&A, or see Dr. Eduardo. Yeah, please go ahead.
Yes, I have a question. I understand that the histoplasmosis guidelines for treatment preferred as a primary treatment liposomal amphotericin B, and I have some problems with obtaining it in Guatemala. There are some administrative problems, but also the medication is in the essential list of medicines of WHO, but it's not in the strategic fund for histoplasmosis. It is only for leishmaniasis and cryptococcosis. Is that true, or I don't know? I have some confusion about it because I've been trying to get it and it's been very hard.
So maybe I'm sure Omar will be able to offer some insight into this, but I would say from the HQ side, it's definitely in the EML list, and we indicate all, there's currently, other than of course Ambisome, we currently list both amphotericin B as well as liposomal amphotericin preparations as part of the EML specifically for histoplasmosis. So yeah, Omar, sorry, over to you.
Sí, thank you. Muchas gracias, doctor Aratón. Eso es un tema que vamos a abordar mañana porque hay una confusión también ahí, es cierto. Hay un precio especial negociado para la leishmaniasis, pero está disponible a través del fondo estratégico. Lo que pasa que puede ser que tenga un precio diferente si la indicación no es leishmaniasis. Pero eso se está discutiendo en este momento y está Juliana, por suerte, aquí, que lo va a comentar. Juliana, adelante.
Thanks, Omar.
Sorry, Juliana will comment.
Okay.
Yeah, please go ahead.
Okay, so buenas tardes a todos y a todas. No, la verdad es en línea con eso que Omar decía, pues tenemos la anfotericina disponible. Vamos a hablar de eso mejor y en mayor profundidad mañana. Lo que pasa es que cuando estamos tratando de leishmaniasis tenemos un precio disponible y tenemos un acuerdo a largo plazo vigente para eso, pero el proveedor no oferta el mismo precio para todos los países cuando no estamos hablando de leishmaniasis. Entonces hay ahí un tema de uso, además de otros tipos de monopolios y exclusividades, y en ese sentido estamos intentando encontrar otras posibilidades de accesibilidad hacia los países, pero también vamos a profundizar el tema mañana, así que les agradezco la oportunidad.
Muchísimas gracias. Entonces, allá yo creo que ya estamos en tiempo. Ha sido una excelente sesión, más de 150 personas conectadas casi todo el tiempo. Muchísimas gracias a los intérpretes de español, inglés y portugués. Muchísimas gracias a todos los que nos colaboraron de Gafi, de CDC, de SHAM y API. Tenemos que encontrarnos otra vez mañana a las 10 de la mañana de Estados Unidos y pasado mañana también en este mismo link. Ahora vamos a continuar con un grupo de trabajo cerrado con las personas designadas por los diferentes ministerios para discutir estos temas justamente como los que mencionaba el doctor Aratón recién. Y ese trabajo va a ser en el otro link que deben haber recibido. Si no lo han recibido, por favor, enviar un mail a Julia Castillo o a Omar Sued. Nos vemos entonces con el resto de todos los panelistas. Diseminen esta información mañana a todos los participantes, a quienes quieran. Recuerden que mañana y pasado de 10 a 12 es de entrada libre a cualquier persona interesada en el tema. Muchísimas gracias. Nos vemos en los grupos de trabajo en 5 minutos.